Good morning, everyone. I'm Dr. Susan Schmidt. I'm the director of the School of Nursing here and the project director for the HRSA grant that's funding this. And we're very excited to have our second annual conference in which we have some fabulous, fabulous speakers today. And we want to start it by having our president of Xavier University, Reverend Michael Graham of the Society of Jesus, welcome all of you. So, Father Graham.
Thank you very much, Sue, and good morning, ladies and gentlemen. As I was walking over here today, what occurred to me, it's cheap and easy, but it's true, is that old Chinese proverb, you know, may you be born and live in interesting times. And I thought to myself, well, there's a variation on that we can run today, isn't it? May you hold a conference on population health in interesting times, you know. Yes, right. As you've been following the news out of Washington, D.C., I'm sure, you just find yourself, if you're like me at all, just kind of going like that over and over and over again. Last night I found myself going like that again, because we don't know what the environment's going to be, do we? You know, that there seems to be this kind of attitude that what's at stake here is a political victory, as opposed to things like making sure more people have health care, that the quality of health care improves, that the cost comes down, that the patient and family experience is better, and on and on and on and on. I was speaking with our keynote speaker a few moments ago, and what John said, and rightly so, is that the devil is very much in the details in something like this. And that seems to be just glossed over in the effort for winning political points and political gamesmanship. And so there's a way in which you might ask yourself, well, what are we doing here anyway? You know, how can we possibly have a conference like this when the environment around us is so incredibly uncertain and just filled with questions and doubts? I would submit that precisely because that is so, what you are doing here today is more important to be done than it was or seemed perhaps 3 months ago, 6 months ago, or however long ago you care to go. That what you are about, the conversations that you are about in terms of population health and achieving those incredibly important outcomes of patient and family satisfaction and improving quality of care and finding a way to become more cost effective along the way, that those kinds of conversations can't be left to Washington. You know, they have to be in places like this. It's wonderful to be able, through the generosity of the HRSA grant, to be able to have this conference. I'd be remiss too if I didn't note that here in regional Southwest Ohio, we have lots of great allies in this work, whether it's at Wright State University School of Nursing or the College of Nursing across just a couple miles away at the University of Cincinnati. And so thank you very much to all of you who collaborate across the region to make sure that the health care we offer tomorrow can really fulfill our best hopes for it. You have a great array of speakers lined up, a very, very full day. I'm sure it'll be incredibly exciting. I know it will be incredibly important. And so thank you very much for being here and your commitment to doing this on behalf of some of the most vulnerable people in our midst, because that's what this is really about, isn't it? So thank you very much. Blessings on your day. Thank you.
Father Graham is packed with things to do today, and so I was delighted that he was even able to come at all with what I know his busy schedule is. So thank you very much, Mike. We really appreciate it. And I need to remind everyone, I've been told to fill out your evaluation form at the end of the day so that you can get your continuing education. And then the other thing is that our breakout sessions, in order to handle the crowd, we're going to have the breakouts in that room, this room, and then upstairs. So it might be a little different than what's in your programs. So now I'd like to introduce to you Dr. Richard Schonk. Dr. Schonk is the Chief Medical Officer for the Health Collaborative here in the Southwest area. He's been a leader in helping our area be one of the most recognized areas, this whole Southwest region, in the nation for moving forward with the primary care initiatives and the various cost payment initiatives, and helping our physicians across the nation learn how to do this. So he's also the leader of CPS, which he's going to, the comprehensive, so, and he's going to share some of that as he then will introduce our keynote speaker, John Auerbach.
Thank you, Susan. And I was just telling John that he and I need to stop meeting like this, because I was introducing him at the OPC PCC conference last fall, and I'm thinking, deja vu all over again. But anyway, we are that's great, and you're in for a special treat with regard to his talk, and well versed in all things in the healthcare world, and I think you'll really enjoy it. I want to applaud Susan for this conference. As usual, Xavier is one step ahead of the game, and they are doing a lot of interesting stuff in the area of team-based care. And I can tell you from being a family physician and being involved in the Comprehensive Primary Care Initiative for the past 4 years that it is critical that we have the team. Physicians by themselves, nurses by themselves, social workers by themselves. Nobody by themselves does this well until we get it together in a team approach. And that really was shown in our Comprehensive Primary Care Initiative. We've had our first 4 years. We were able to reduce the avoidable hospital admissions by 25% across those 75 practices, and at the same time keeping costs flat. That is a big success story, and we were one of 7 regions in the country to do this, so it got it started in Cincinnati. And since then, CMS has decided to expand that program to now 14 regions, and we are expanding it, and they are expanding it across the state of Ohio. We are very fortunate that we will be heading up that project across the state. A bit daunting, 562 practices. I sit there and think about that every night. But it is something that is very exciting, that we can take this, and if you do the math, 562 practices represents healthcare rendered in primary care for about half of the state. Now let's just think about that for a minute. Team-based care in comprehensive primary care, which is what it's built on, is going to be rendered now, starting January 1 of this year, to half of the residents in the state of Ohio. That's a watershed. And that doesn't even count the CPC Ohio, which is part of the state innovation model, which is bringing in all of the FQHCs, many of the university clinics, and several other practices that focus on special needs Medicaid population. So we are going to be well over half of the population getting their care in a team-based model. That should give most of you some comfort, especially as we talked about all the changes going on in Washington, D.C. I get asked the question on a regular basis, how certain are we will this continue? And my answer is that it will continue because, one, macro legislation, that whole change in the way is all based on value-based care. That was a bipartisan, by far a bipartisan approach. If you take away CPC and the ACO and the team-based care approach, all you're left with in MACRA is a MIPS reporting pay-for-performance effort. So we feel very confident that that's going on. Our sources at CMS that we talk to with regard to CPC Plus say it's in the budget. They don't hear anything that says that they're going to back off on the pay-for-value approach. So pay-for-value in primary care, I think, is something that you can be relatively optimistic about. So with that, I'm going to, I do also want to mention that here in Cincinnati, because we started it and because it's expanded across the state, we will have now 80% of adult primary care in this Southwest Ohio, Dayton, Cincinnati region being rendered by a CPC practice. So 80% of adult primary care. The SIM approach will bring in the pediatric side of Medicaid, but that is an amazing statistic. So all of the systems, from Kettering to TriHealth to UC and on, have bought in to this approach and have their practices lined up in this particular project. So we feel, again, very proud for this community to be leading the way in that particular work. But I wanted to shift now to Dr. Auerbach's talk, and I wanted to be able to give a connection. So what he's going to speak about is how do we take this team-based care approach and make it connect to the community? How do we take it and connect it to all the policies that are going on? And what is the state of that policy so that we can begin to connect the dots, if you will? So that's going to be, I'm going to be sitting here listening very intently because that is one of the things that all primary care practices ask themselves. They sit there and they say, I can take this patient so far from a clinical, but I need to take the clinical and connect it to the community. I need to take that disease-based approach and connect it to the prevention approach. I need to get ahead of the game and keep this from happening down the road so this patient doesn't suffer from this or my other patients do not suffer from this. So how do I reduce those risk factors, and what part does the community play in helping us to reduce those risk factors? So all of those things, Xavier's one step ahead of the game. That's exactly the question that's being asked by all these primary care practices as they engage in this comprehensive primary care program. So with that, I want to introduce John, and I was taken aback a little bit because when I was reading his bio, the first phrase I ran across, and I quote, "He is responsible for protecting the health of every community." I thought, wow, talk about accountability. I thought, this is fantastic. But anyway, he may want to go back and check that. I don't know. But anyway, but he is a pioneer in disease prevention and overseeing the national priority in doing that. He comes well-versed. He's president and CEO of Trust for America's Health, and then has been the associate director for policy at the Centers for Disease Control and Prevention. So well-versed in all of those areas, and I'm going to welcome him to the stage, and he will tell us how he's going to be accountable. So.
Well, good morning, everyone. I want to do two things initially. First, to thank Richard and Susan for the work they've done for today. As you heard, I was here earlier, or just last year, to talk about the really good work that's being done in terms of primary care and team-based approach and what Richard was just talking about. But that's where I met Susan, and what I said to her last night is I couldn't possibly say no to Susan. She said, "Come back," and I would do as you tell me. And the second thing I would say is I clearly need to go back and more carefully read my bio if it says that I'm responsible for everybody's health and well-being. So clearly I'm not. Let's just see, do I have here, I have this. And so the topic that I'm going to focus on today is the challenge of providing health and promoting health, providing health services, promoting health more broadly at a period of time where we have enormous change and uncertainty. And if there's one defining factor, I think, of the last few years, it's been a lot of change and uncertainty. Nonetheless, it's important, as your work illustrates, for us to be aware of what's going on and to focus on those main trends that are likely to stay in place, and then to think about how do we pay attention to some of the key issues. Now, I just would start out briefly by saying I have had a long career. I was a city health commissioner for 10 years. I was a state health commissioner in Massachusetts for 6 years when my task was implementing our initial healthcare reform effort, which preceded the Affordable Care Act. I then worked at a university, Northeastern University, where I worked very closely with the nursing school for a number of years. Then I went to CDC and worked on some of the issues related to linking clinical care with what we in public health refer to as population health, total population health, focusing on the conditions that are likely to lead to optimal health. And then just in the last 2 months, I have moved to Washington, D.C. and head up an organization whose acronym you see on that slide, the Trust for America's Health. It is a nonprofit, nonpartisan organization funded by foundations long-term, and our focus is on federal policy, the federal budget, and I'm continuing to work on the issues that I worked on as both a city and state health commissioner and at the CDC with a particular lens of being involved in what's happening on Capitol Hill and in the White House. So as you might guess, this is a busy time. These are some of the activities we do at the Trust for America's Health. I'm not going to go into those because I'd rather focus on the larger issue of health care. I have this slide in there because I've only been in this job at Trust for America's Health for 2 months, I sometimes forget who I am and still think I'm working at the Centers for Disease Control. And so you will hear me talk about a number of things where I'll say we, and I'm really talking about the CDC because I'm still going through my identity crisis. But I'll try to clarify who I am during different parts of this talk. So I'd start out by saying this is a period of time when there's a very significant change. And these 5 different phrases that you see there each represent what I would say are trends that are likely to continue and ones where we need to be well prepared to address those. And so let me just talk to you a little about each of them. The first is the issue of increased access. And here, just to summarize the facts, where we have in the United States now increased the number of people who have insurance by 20 million people over where we were prior to the Affordable Care Act. Part of the difficulty in the recent efforts in Congress in coming up with a new plan is they're not starting from scratch. They've got those 20 million people in place, and there was enormous pressure on Congress not to create a situation where millions of people were going to lose their insurance. I can talk more about what happened in Washington, but people in the Senate in particular said, we're hearing from those governors of the red states as well as the blue, do not pass something that's going to lead to millions of people losing their insurance. So I think that it's very likely that we're not going to see a significant reduction in terms of that, at least for the time being. One never knows about the future. And so I think we have to think about continuing that coverage. What is it going to mean? Some states are even today considering whether they're going to move to expanded Medicaid. By the way, the other thing that was interesting that we analyzed at CDC was that the states, many of the states that didn't expand Medicaid had the largest percentage of increase in terms of insured during the ACA, because many people who were eligible for Medicaid didn't know it, got onto the exchanges, found out, enrolled, and also because of the subsidies for low-income people. So in state after state, there have been significant increases in terms of insurance. The second trend, as you heard Richard talking about, is this move from fee-for-service to value-based contracting. It's not everywhere. We're not going to see the total elimination of fee-for-service, but the trend is towards value-based contracting, paying attention to quality outcome measures, and so the work that Richard was talking about, I think, is an indication of how this is continuing, and it's continuing at a pretty good pace, with Ohio, I think, really illustrating where the country is going to be going. And so I think your experience in terms of that is a lot of people in the country are going to say, oh, we can see the progress that's being made in Ohio and learn from that. That does create, for people like me that care about prevention, opportunities. The opportunities value-based contracting creates is that there's more flexibility in terms of thinking about what you can do to achieve those outcomes. When you are locked into fee-for-service, you're paying for units of service that are pre-established, and your flexibility is pretty limited. When you're value-based contracting, there's greater opportunities for a practice, a hospital, a health system to say, hey, you know, we can drive down costs and we can meet those quality standards doing something unconventional if we think it's going to work, if the evidence is there. And so many people in public health are paying attention to that. And I'll give you some examples of some of the services that wouldn't have been possible under fee-for-service will be possible and are possible under value-based contracting. Okay, a third national trend is the emerging clinical care models. And there, for the first time, we do have a federal policy about the best way to receive care, and the best way to receive care is through patient-centered medical homes, where, you know, it's in some ways it's the old-fashioned model of having a primary care doctor who manages things for you, but increasingly it's in this group practice where there is a possibility of having a range of different disciplines available, all coordinated well. And so thinking about that is, that's really what people want. That's what people want in terms of getting health care. Rather than feeling like they've got to go to 5 or 6 different people and be their own case manager of knitting it together. And it's just better care. It's better care to have that coordinated patient-centered home model. This chart, this is a few years old now, the maps that are shown here, but what this shows is the increase in the number of accountable care organizations in the country that now care for a good deal more than 20 million people. And then the green, I think it's the green, is the federally qualified community health centers. And they, too, now care for a good deal more than 20 million people. So a significant increase in federally qualified community health centers, and that's growing rapidly, and a rapid growth in terms of accountable care organizations, both of which largely practice from a patient-centered medical home and value-based contracting approach. Okay, national trend number 4 is that the demographics of the country are changing and the health needs are changing, and we're not as well attuned to that as we might be. So what are examples of that? Well, the chart indicates one of those examples. You may not be able to see the specifics, but it essentially shows you the percentage of the population that is over 65. And if I was in a room of public health people, and I said to them, how many of you have specialized programs for people over 65? Virtually none of them would raise their hand. They might say, well, I think we do flu vaccines, so that, you know, and some of those reach the elderly. But if you look at what the public health system funds, it doesn't fund specialized programs for the elderly. There's virtually no cognitive impairment programs. There's virtually no sensory deprivation programs. And I think even in nursing schools, I don't know if this is true of Xavier or not, but many nursing schools don't have a strong focus on geriatrics. That was certainly true at Northeastern University when I was there. It's a terrific nursing school, but there wasn't a strong focus on the elderly, and the dean of that school really worked hard to change that, but that's an example of we've got to sort of, in many of our models, step back from the models that we've inherited and look at whether or not we're focusing on the changing demographics. The changing demographics in the country also are related to race and ethnicity, and so making sure that we're focused on the different populations and understand their cultures, their specific health profiles, and how we need to tailor our provision of care to those populations is another example. So know your population, know its demographics, understand those differences, and they have different health profiles. That's trend number 4. Trend number 5 relates to the public health system. And here I'm largely talking about governmental public health. So I'm talking about CDC, I'm talking about the Ohio Public Health Department, I'm talking about county health departments and city health departments across the country. I'd first of all make a pitch that all of you be familiar with your public health partners and the public health systems in your community. They're important partners for you to know about and support. That sector has in fact been losing resources and people since 2008. The estimate is 50,000 fewer jobs in public health across the country since 2008. When the recession largely ended, those jobs didn't come back. It also has been changing in general, not everywhere, but in general it's been changing so that it provides less of the clinical care direct services that the public health sector had long run. You know, the public health sector often had safety net clinics, so you could, in many places throughout the country, that's where sexually transmitted diseases, tuberculosis are treated. Also, there are vaccination clinics in a number of those locations. There's screenings. There's reproductive health services. The WIC program is often linked there. There are a number of different services, and in some parts of the country, particularly in the South, that's primary care for many people. It's not comprehensive primary care. It's not the patient-centered medical home. It's a limited number of services, but it's where people have historically received their services, particularly when they didn't have insurance and there weren't practices nearby that they could go to. So that the movement in the last several years has been away from that. Public health is doing less and less of that. Partly it's the 20 million people, and partly it's the expansion of community health centers. And what public health has done is it's moved increasingly to think less about the immediate direct service and more about moving what we sometimes refer to as upstream, thinking about whether or not you can just prevent poor health, you can promote good health by doing certain things in the community, in people's lives that encourage that. You'll hear me refer back to that because it's important for folks to be working on that in complement to the provision of high quality, good care. And I suspect a number of the clinicians who are here, both nurses and others, are either involved in that or familiar with it. So those are the 5 big trends, and I'd argue we should expect those to continue, and those awareness of those and linkage to those are important. But you know, I'd like to move now from the 5 big trends to a more personal examination of what those trends might mean to a particular patient, and how we can think about adapting care and services to meet that patient's needs. So let me introduce you to Fran Edwards. Fran Edwards is 55 years old. She's one of those 20 million people who didn't have insurance and who sought care when she needed it. And so that meant in an emergency if something happened. But largely, she considered herself relatively healthy, but she knew that there were things she should be paying attention to. So she was a smoker, for example. She was gaining weight, and so her weight was a problem, and she wasn't exercising. And she knew she had asthma. She'd been to the emergency room a few times when she had a bad asthma, out of control asthma incident. And with her weight gain, she also knew from a screening she'd gone to she was pre-diabetic. But she wasn't taking medications prior to becoming insured. So she got a subsidy through the exchange, and so she now has insurance, and she started seeing a doctor, and that was great. So she had a high-quality group practice, team practice, the way that Richard was explaining, and her medications were covered. And she now had a way of beginning to think about, how do I control the asthma? How do I control, how do I maybe try to give up smoking in a more systematic way? How do I think about my weight? And, her doctor was counseling her and saying, all the right things. I can help you in terms of some medication to give up smoking. We can, but, in terms of the prediabetes, you've got to take some steps yourself. You've got to really work on the weight, exercise, and food. Good conversation with her about that. With asthma, here's the medication that you need, and, use that when you can. And so, for many people, over the last several years, as we've thought about the ACA and we've thought about good quality care, this was a real success story, because what was problematic before now was more under control. But as we step back and say, is this optimal health for Miss Edwards? I certainly would say from a public health or a health system perspective, she's not in optimal health. She's getting a necessary but insufficient response to her current health. And the reason that it's insufficient is she's got a lot of things going on in her life that make it very difficult for her to optimize her health. She'd like to exercise, and it's very hard for her to do that. She works pretty long hours. She comes home. She wants to cook for her family. So she doesn't have, there's not a gym she's going to. And what she would do is walk with her girlfriends in the neighborhood, but she doesn't feel safe doing that. And there isn't a park nearby. The streets are kind of organized in a way that makes it difficult for her to take a walk in the neighborhood. So there are real obstacles to her exercising, in spite of the fact her doctor's counseling her to do that, and she'd like to do it. She also doesn't have a lot of excess money. And so as her doctor's counseling her about eating fresh fruits and vegetables, she actually doesn't have an easy way of doing that, both because of her concerns about making sure she's got the right amount of calories on the table and her family's full, and also even in her neighborhood, there's a limited number of places where she can buy fresh fruits and vegetables. So again, she'd like to do that. She's hearing her doctor. There's some real barriers in terms of her being able to comply with that. She's under a lot of stress, and so she feels like that's the main issue she's grappling with as she's thinking about smoking, that the stress is creating problems that make it hard for her to think that's a priority for her to work on, and some of her stress relates to behavioral health issues in her family. And then finally, she's living in what you might call subpar housing. So while she's got her asthma medication, she's in housing where there's some mold problems that are triggering her asthma. And so if we think about what she needs, if our goal is, let's have Miss Edwards in optimal health, we definitely want the care, but the care isn't enough, because the doctors and the nurses are going to be incredibly frustrated seeing her on a regular basis, feeling like she's just not making progress in terms of optimizing her health. It's frustrating for you as clinicians if you hear that. It's frustrating for her, and it's not good for her health. So thinking about her health in a global way, keeping in mind those characteristics I was mentioning, is important. This, I think, what I would argue is what she needs, and where there are some opportunities with those trends to think about her needs. The first one pretty much met. Now that assumes we keep the insurance coverage with subsidies, because if she loses her subsidies, she'd be one of those 24 million people that you read at the Congressional Budget Office said would lose their insurance. She can't afford health insurance without there being subsidies at the level she's getting. But what would also help her would be a evidence-based initiative that has been shown to work in many different communities, funded by public health, and that's to have a community health worker or a nurse do a home visit and look at the conditions in her home that contribute to her asthma. The evidence is shown for people like Miss Edwards, within as little as a year, this can pay for itself. And it involves going in there and saying, you've got a rug, and the rug is a problem. It's gathering dust, and that's contributing. You've got the mold and the mildew. Maybe we can talk to your landlord. There's some other things you can do in order to reduce the triggers in your home. Let's walk through your home and work on that. It can even be looking at cleaning supplies and seeing which ones might have smells or ingredients that would trigger. So you can pay for that in a well-designed value-based contracting arrangement. It's not automatic, but you've got that flexibility that you wouldn't have under fee-for-service. And so where you see that being paid for as a component of care, it's because there's a value-based contract that says, take a look at that. A really good example of that you may want to hear about is Camden, New Jersey. How many of you have heard about that situation in Camden? Well, in Camden, there was a clinical practice that was noticing a significant increase in terms of hospital visits for asthma among its patients. They ended up looking in the data and looking at geocoding of the people who were going into the emergency room. And over time, what they noticed is that the largest percentage of people who were being in the emergency room for asthma lived within a one-block area, and a very large percentage of them lived in 1 or 2 buildings. And so the nurses and other educators did home visits and found out it was because the building was what you might call a sick building, and it contributed to their asthma attacks. And so paying attention to cleaning up the building was necessary in order to address that. So that's the kind of approach that more and more is possible with a value-based, a creative approach that thinks about how we can use some of those activities, pay for some of those activities to make them accessible. So a second example of that is the Diabetes Prevention Program. How many of you are familiar with that? Okay, so the Diabetes Prevention Program is again, an innovative approach. Together, the asthma program and the diabetes prevention program first started as with funding from foundations and from the public health sector with grants. And then they were evaluated, and so now the idea is once they're proven effective, can we make them part of routine care? Diabetes Prevention Program is a lifestyle change program with generally 20 or more sessions, provided in a community setting. In many places, that's the YMCA, by a non-clinician who does exercises and talks to people about medication compliance and some other things. There's a whole curriculum, a formalized curriculum. It's been evaluated and shown to be very effective in terms of reducing costs and improving health for pre-diabetics. When I was at CDC, we spent years validating those studies and working with CMS to convince the actuaries at CMS that it really did work. You really not just got healthier, but you saved money quickly for CMS. And so it was able to demonstrate that, and it's now in the queue for reimbursement from Medicare as of 2018. I think it's still in the queue. I don't think things are changing in Washington, but I think that one is pretty much going to happen. The significance of that is that's Medicare for the first time paying for a community intervention, not a clinical intervention, a community-oriented intervention where the person conducting the intervention is not even a clinician. The person's been trained, there's quality measures, et cetera. But it's a new model, and again, it shows what you can do when you think outside the box in terms of thinking about moving in an innovative way. Behavioral health services, I think she clearly needs that for her son, and we're seeing more and more the effort to carve in behavioral health into a patient-centered home practice to make sure that we don't have separate systems where people have to figure out, what do I do, how do I go about accessing those services. More and more when I do meetings around the country with different groups, if I say to them, tell me the #1 health issue you're facing, people will start with behavioral health, both substance abuse and mental health. And that was not true 5 years ago. Now, I'd say that's risen to the very top in terms of concerns. She obviously needs things related to neighborhood safety if she's going to exercise. That's an issue for her. Affordable, healthy foods, and help in terms of the mold in her apartment. So not all those things are easy to solve, But if our goal is optimal health for Miss Edwards, that's the list. That's part of the list, and it goes along with the quality of care. So at CDC, we thought this is a little overwhelming to try to think about the optimal health for Miss Edwards. It's sometimes hard enough just to think, how do you get her into a clinical practice where she hasn't been, and how do you get her the right care? So what we developed was a framework that we thought could be helpful for people, a framework for thinking about preventing poor health outcomes for someone like Miss Edwards. And we also thought it was important to have this framework because in many states, like Ohio, when you have SIM and you have other redesign activities of the healthcare system, you sometimes get people from different disciplines at a table, and you could be using the same words and meaning very different things. You can hear people talking about prevention and population health, and really everybody using those terms has a different definition in their mind. You know, there are, sometimes when you hear people talk about population health, what they're really talking about is we want our patients to have physicals every year, and we want to make sure that they're up to date on their vaccines. You know, insurers are maybe thinking about globally, what are the services that we're providing that are preventive in nature, and how are we doing in terms of tobacco use among our patients? Public health people hear those terms and they think it's everybody in Cincinnati, or it's everybody in Ohio, and we have to think about how we create healthier communities for people like Miss Edwards and not what's happening in a clinical visit. So at those meetings, these are real debates that have taken place in the discussions in Ohio and other places, just people figuring out what are we talking about here. And what we came up with is saying there's not a right definition. There's not a, you know, someone can claim, if you're going to talk about population health, you have to use my definition. There really are ways of thinking about the importance of each of those interpretations. They're each necessary and all need to be attended to. So we found it helpful to break them into this notion of 3 different buckets, each of which needs to be attended to. And if you're focused in one of them at any particular time, and you can't do the others, at least be aware somebody needs to work on those others. There needs to be attention to the other if we're going to optimize health. So what are the 3 buckets? The first one is traditional clinical approaches to prevention. So these are the things that have long been covered by insurance that we consider routine clinical care in a clinician's office, usually a doctor's office with a nurse there. That is, and they will involve vaccinations and screenings and colonoscopies and mammographies and counseling on weight and cigarette smoking. So those things should happen, testing for high blood pressure. And the truth is we're not doing so great as a country, even on those. Those largely are covered by insurance, but our numbers aren't great. So we don't have, most states have fewer than 50% of the people who should be vaccinated for flu vaccines who are vaccinated, for example. We only have about 2/3 of the people who need colonoscopies that get colonoscopies. We only have about 50% of people with high blood pressure that have their high blood pressure controlled by medication. So there's a lot more we could do. Now, Richard talked about value-based contracting. Value-based contracting is specifically designed to drive those numbers up by focusing people on looking at those numbers. Because when we talk to clinical practices, they very often think they're doing much better than they're actually doing. But when you measure it and give feedback and you really work at it, you can make a significant change. At CDC, when I was there, we developed this approach, this initiative called 618, where we wanted to work with insurers and clinicians to improve those numbers for services that had long been recognized as important, but where we weren't doing such a great job. And the way that you can improve that is you can design incentivized systems so that you create financial incentives, quality incentives that say you're going to be ranked as not doing a great job if you're not focused on those. But in terms of paying attention to the insurers in prioritizing those are looking at do they really make a difference in terms of health, or are they just those things that people should do, but it doesn't really make a difference? And number two, does it make a difference in terms of cost? Because we want to keep our premiums down, and so if we're going to provide more services, demonstrate to us that this is cost effective to us. Not larger society, but most actuaries and insurance companies want cost effectiveness to them. That also means they want results in 5 years or less, because they may not have those patients for 20 years. So if I'm arguing, do this, it's the right thing, and over the course of the generation, this person's going to be better, and 15 years from now, they won't need hospitalization. My experience with insurers is they hear you, they very often agree that's the right thing, and then but in many cases they say we just can't do that. Our goal is keeping premiums under control, and so thinking as a generational change or 10 years is beyond our sense of priorities. So we looked at this program and we said, what do we know at CDC where there's definitive programs, 5 years or less, you save money and you have positive health outcomes? And we identified 18 preventive measures. Most of those were what I'd call the traditional ones, but ones where we now know how to focus on quality. So I'll give you just 2 examples of those. One was making sure that people had access to smoking cessation medication, all the FDA-approved medications with no cost. We've learned that if you charge $5 for that medication, people won't get it. If you charge, in some cases, $1, they won't get it. And we also know the total FDA-approved list is because some of those medications work for some people, not for others. So if we want to really drive down smoking, that's been proven as no-cost access to all FDA smoking cessation programs. That's one of the 18. Another one that's a traditional, I would call traditional like that, is for reproductive care, cover long-acting reversible contraceptives. We know those can be very effective. There's growing evidence they're incredibly effective in the states that have agreed to pay for them in Medicaid. And, but many insurance companies will cover some reproductive services, but not long-acting reversible contraceptives. So that's another value. It's proven. You save money and you improve health. So here's the example there. So bucket 2. So what is bucket 2 about? It's the opportunity that exists with the value-based contracting to think outside the box, where you can say, what can we do outside of the traditional clinical setting that will help our patients? And the 2 examples that I offered you were the asthma home visits, where we now know that for a profile of patients, that will make the difference. And it will make the difference in 5 years or less in terms of cost and health outcomes. The profile it'll make the difference with is people who already have some indication of emergency room use, hospitalization, or uncontrolled asthma attacks. But the diabetes prevention program is another. So part of 618 is identifying those evidence-based programs and making sure we're really thinking outside the box. Now, here's where I would say you could play an important role in terms of thinking about this. The things that you know for patients that you know would make a difference in terms of that patient's health that you haven't been able to do, we need to identify those, study those, and where we have the solid evidence, make the case to insurers that we should be paying for those as part of routine care. I'll give you a few other examples of those. The nurse-family partnership has been incredibly evaluated. These are 3 years of home visits that has been cost-effective in a global sense and definitively shown to be good for health. Very few insurers pay for that. But that's an example of a proven intervention where we should now be saying under value-based contracting, pay for nurse-family partnerships. And there's several others. That's bucket 2. We've got to be creative. You've got to have data, and you've got to work collaboratively with the payers and the large health systems. But this is the moment to do that. We won't always have this moment. It's important to be thinking about that. That's why we classify it as bucket 2. It's not going to happen easily. You need the data. You need to make the case. And then there's bucket 3. And bucket 3 moves away from bucket 1 and 2, which was focused on the patient and focused on what could be paid for with insurance. Bucket 3 is not patient-focused. It's community-focused. So it's thinking about the neighborhood, the city, the county, the state. And it's saying, what can you do that's going to optimize health? And there, too, you want to be able to say, let's look at the evidence. Because there are many things that maybe sound like they would work, and they're common sense, and very often those are the right things to support. But we also have studied this when I was at CDC and said, what do we know about a policy, a law, a regulation, that are there some that if you put those in place, we can say definitively to a mayor or a governor or another elected official, in 5 years or less, governor, this will not only improve health, but it will save money for the state. We'll give you some evidence of that because you may be looking for those wins. And so at CDC, we developed, we looked at all the research, just like we did with 618, and we found that there were, in fact, 14 interventions where there are probably many more than this, but these were ones that were very thoroughly studied with well-designed research methodology that showed health improvements in 5 years or less, not just behavioral change, but health improvements, and cost savings over time, not in 5 years, but over time. And they're interesting. I suspect you can't read these all, but they're interesting in part because the blue are what the public health system works on very often. The public health system works on things like wearing a helmet if you're riding a motorcycle or a bicycle, or for people who are using injection drugs, having safe, clean needles available either through a pharmacy or through a needle exchange program. There are a number of those that are listed in the blue, 8 of the 14. In the red, very interestingly, there were 6 approaches that were community-wide that showed they worked very effectively, and they weren't in what we'd call the health sector at all. They weren't in what we think of as either public health or health care. They were things like working on mass transportation. They were things like retrofitting buses so that they were less polluting. They were economically identified in terms of such things as low-income home improvement loans and low-income tax credits. So those were studied and showed. The study specifically looked at not does this help the person economically or make their life more convenient, but the studies that were done looked at does this improve health, and we found that those did. Now, there may be many more, as I said, that are outside of the health sector, but we felt good about, for those folks who are struggling to make the case that working at that larger community level is something you can make a return on investment or business argument about. It's good to know that CDC has given the stamp of approval to at least 6 of these outside of the health sector approaches and 8 of the public sector, public health approaches that we know will make a difference. So I'd encourage you to look at these. By the way, you can get to if you get to cdc.gov, that's a good site, www.cdc.gov, then the 2 locations to look at after cdc.gov/, one, type in the word 618, spell it out, and that will give you the 18 evidence-based packages for those interventions in bucket 1 and bucket 2. They make the case to an actuary, to an elected official, to a health system. These work, here's the studies. They kind of put it in accessible language. If you're interested in these policy changes, then you get to www.cdc.gov/, and you just write in HI5, high 5. It stands for Health Impact in 5 years or less, HI5. And there, too, you'll get 14 evidence packages that will make the case that these are good things to do. we have found, oops, maybe I'll just mention one. When we unveiled High Five, we were very conscious of unveiling it in states that were not known for being the liberal, we love regulation kind of states. Because what we thought it was important to see, could you actually do these in other locations? So, for example, I was living then in Atlanta, and we highlighted Georgia as doing one of the ones that are in the red, which is focusing on early childhood education for 3- and 4-year-olds. And the health commissioner in Georgia, and the governor of Georgia, and the head of education of Georgia, conservative folks, were very proud to demonstrate that their investment in early childhood education was an example of a state taking the initiative, not simply because it was good for education, but because it was good for health. They consciously knew that, they were proud of it, they highlighted it. And we've worked since then with different ones of these initiatives with Mississippi and Texas and other states where, this is they're very often led by folks who want to be shown something works, and that it's not just trust me, if you do this, it'll be better. These are where the evidence is there. So again, 3 buckets: working in the traditional clinical setting to increase the practice of what we know works. Bucket 2, in the innovative bucket, is for insurance getting more out of the office, complementary services that are in the home or the community setting for a patient where the evidence indicates these work and they reinforce the message. And then bucket 3, work at that state, county, city level. We look at the current situation, and as we work collaboratively with some members of Congress and we look at the Trump administration's appointments at Health and Human Services, and we said, is this approach still relevant? And the indications are from the folks we've talked to, it is. We convened a meeting just about a week ago in Trust for America's Health, where we brought people in who are public health and healthcare folks representing the broad spectrum, an invitation-only meeting, 28 people. We brought people in as extreme as you can imagine on one end of the other. People who were interviewing for jobs in the Trump administration on one end, people who wanted nothing to do with the Trump administration on the other hand. But they were all public health and health people. We thought, well, we're going to try to see if we can have a civil discussion behind closed doors. It was really I felt like a third-grade teacher, where I started the meeting by saying, okay, here are the rules. Nobody can insult anybody else. Nobody can roll their eyes. There's no sarcasm here. And your job is not to convince people that you're right. Your job is to listen to them. And everybody can say what they want, but your job is listening, and you can ask questions. And it was a great meeting. We really didn't know whether people would be able to last the whole day, but they enjoyed it and felt like it was healthy. And what they affirmed, what we wanted them to do, was we organized it around different topics, like I'm presenting today, to say, are these relevant to you? Do these make sense to you? Are these trends still here? And are these services and still relevant? And by and large, we got consensus in the room that those made sense to them, and that they weren't areas of disagreement. We stayed away from the third rail of, do you support the ACA or do you want to repeal the ACA? We didn't go there because we knew we wouldn't have. We knew where people stood. But on these issues, the ones I'm sharing with you, the support was solid in terms of this makes sense. Now, this would be problematic, and I put this up here because I planned this before last Friday. And so I wanted to talk to you about some of the challenges that we anticipated. This is from the Congressional Budget Office, and this was their explanation. The blue line represents the current estimate with the ACA in place of continuing to have about 10% of the population uninsured, but about 90% with insurance. And then the red line was what was the estimate of the Congressional Budget Office about what would happen if the House bill passed, which is we'd increase the percentage of uninsured to 19%. So, you know, these discussions are not over. So, but I would say to you that this, from a nonpartisan perspective, I'm a nonpartisan person, I would say I'm concerned about the red line. That we know health insurance is correlated with better health. And for Ms. Edwards and other, we don't want people like that to lose their health insurance. So in the continuing discussions, we would just say, important to pay attention to this. You don't have to be partisan to support access to health insurance, and we know that you know, objective assessments like Congressional Budget Office are helpful in terms of making that assessment. Keep it on your radar screen. Things that we're continuing to be concerned about in Washington are related to the budget proposals. And I'd raise that to you with thinking about Ms. Edwards in mind. I don't think you can see the numbers here, but I will share with you that in the President's initial proposed budget for 2018, there wasn't a lot of detail. It was sort of at the Secretariat level. More detail will come in about a month or so. But the detail that was there involved the President proposing that there be an 18% cut of all of the Health and Human Services Secretariat. That's the Secretariat where CDC is, where CMS is, where HRSA is, the Substance Abuse and Mental Health Services Administration is there. So we don't know whether, you know, one agency will be cut by 30% and one will be cut by only 10%. So our assumptions are, for the sake of our discussions with our congressional leaders, are there may be an 18% cut in every single agency. Now, we are, as a nonpartisan group, concerned about that because those agencies do provide a wide range of different important health services that we think are important for people in health, in particular, to be aware of and consider what they want to do with regard to that information. 18%'s a big cut. But I'd also highlight for you on this slide that there were very significant cuts in other departments where we know that those departments do work that have an impact on the health conditions in people's lives. And so going back to Ms. Edwards, housing for her is a major contributor to her health. Safety to her is a major contributor to her health. And so when we look at big cuts in HUD and including some proposals like community development block grants, which do a lot of neighborhood-based work to create healthier conditions in communities, some of the food assistance programs, we get worried about the potential impact that can have in the bucket 3 arena. And again, I would just raise that as people who want to optimize health, it's not enough for us to pay attention to, is there good clinical care? We're hopeful that the work that Richard's involved in, the CMS supports, will continue. The evidence is good about that, for now. But we have to pay attention to that. CMS matters a lot. Medicaid and Medicare seems, for the time being, they will stay in place. But we do need to pay attention to these other arenas where if there are significant cuts in some areas, our patients will become sicker. Their lives will be much more difficult. And so we think about that. I'd also raise the issue of global climate change. I think there's evidence that we saw in the work we did at CDC and in other arenas that has a direct correlation to health. We saw, for example, when we're looking at Zika and we're looking at other mosquito-borne illnesses, we're definitely seeing that as the temperature rises, those mosquito-borne illnesses move to new parts of the country where they weren't before. And that's, if we look globally, we see even more of that. But particularly in those warmer areas, this is tricky. So paying attention to those issues and thinking, do they have an impact on health? What's our role as clinicians and people who want to optimize health, paying attention to those? So I'd close with this. I would say it's good for us to think about policy. It's good for us to think about how we have an impact in Washington and in our states and our cities at the very high level, but it's really good for us to continually be linking that to the individual person sitting in front of us, or to start with the individual person in front of us and thinking about what's going to make the difference in terms of that person's lives. So I'd leave you with these concerns around Ms. Edwards. In terms of the primary care, her primary care and her meds, the key thing for her is subsidies, so her premiums are low, low deductibles, not paying for her medications. The policies that allow that to happen is going to make the difference in terms of her being able to retain her care. In terms of getting things like the asthma home visits or the diabetes prevention program, that means that from a policy perspective, CMS needs to continue to do what it's been doing, which is encourage innovation, flexibility, and models of care that allow folks to attempt to do new and different things. In terms of behavioral health services, there we need to make sure that those are covered. Again, it didn't pass. I'm not here to be partisan, but we were concerned that language was taken out of the House ACA replacement that weakened the requirement that behavioral health had to be an essential component of insurance. And so we thought that's not a good thing. That behavioral health needs to be a part of insurance in the same way that other key physical costs are. Neighborhood safety is going to be based upon a number of different things. It's certainly based upon things like police, but it's also based upon investments in the community and making sure that communities are vital, that space is occupied, that there are social services, recreational services in communities, that there are parks. Those things make communities safe. It's not simply the police. So looking at the parts of the budget that pay attention to that. Affordable foods is also very much connected to that. And then housing. I mentioned that the study that showed that low-income home improvement loans to do things like remove mold and mildew have been shown to not only help the person out just in terms of the quality of life, but make people healthier and save money over time. Those programs tend to be funded out of HUD, and so if you worry about those, paying attention to the HUD budget makes sense. In closing, I would say, I live in Washington now, and so when people ask me, aren't I pessimistic, or that something happening every day that would make me, be more concerned, I would say, this is a time of a lot of uncertainty and instability. I'm actually not pessimistic. I actually think, as I've traveled around the country, people are focused on what their communities need, and they're very much focused on when we talk about health, in the community after community I've gone to, red states as well as blue, I have not been in a room where people said, we don't need health insurance, or it's okay if people lose health insurance. I've not heard that from, regardless of political stripe. I've not heard people say we don't need to be paying for both bucket one or bucket two approaches. I think on bucket three, where we talk about the practical reasons that people are healthy, I've heard consistently people recognize that. How to go about addressing those issues, not so clear. But I think there is this general recognition that we're in a different place now, that we need to make sure people have access to high-quality insurance, that it's affordable and it's accessible, and that we're not thinking in a narrow way. We're really trying to think about changing the conditions in people's lives so that we can optimize health. But it does require our being aware of what the possibilities are, thinking about the policy issues in our own community, and working collectively to improve them. And I know that the work that Xavier's doing is very much aligned with that. And everything that I've heard about the way that Ohio is thinking about primary care and patient-centered medical homes makes me think that the work here is moving in that direction too. So thank you very much.
Am I on? Good. So, John, very good, and I really appreciate a lot of the insights that you bring to this. I want to stop and say, again, Xavier's ahead of the game. We do have our health commissioner from the city of Cincinnati Health Department, Marilyn Crompton, Dr. Marilyn Crompton.
Yes, I should have introduced
She's
you.
actually going to be in one of our breakout sessions, so you guys will have a chance to test this here locally and see how those connections work. So, interesting conversations that are going on in Washington right now, and we want to open this up to questions, so get your questions ready, but just to kind of start things off, I was intrigued by your group that got together from both ends of the spectrum. And one of the things that we've dealt with in comprehensive primary care that I think is was kind of a new paradigm, if you will, for the physicians. When you start talking about value-based paying for value, that equation is quality over cost. And the clinicians became very interested suddenly in cost and in how they could deliver the care in a very responsible, cost-effective manner. It seems to me that same lesson could happen in Washington. It seems like if we're going to truly, because I'm sure that you heard in these conversations, I'd be interested to see what kind of that dialogue looked like. But, you know, the national debt continues to go up. Everybody's talking about how much can we afford. Is there a movement, if you will, as we talk about these cuts, about looking at where dollars may not be spent all that well? And do we need to redirect those dollars?
I think we're in the early stages of the administration. So if the question is within the new administration, is that?
Yeah.
I'd say we're in the early stages, and so I don't think we know definitively about that. In part because people are still being appointed. Most of the federal agencies haven't been appointed. They're still staffing up. I think that there is an interest in cost savings. And I think there's an interest in quality among the people at HHS. I think there may be a difference of opinion about how do you achieve that, and I think time will tell.
Okay. I'm just wondering if they're kind of applying the same concepts that they at the department level that they're asking the clinicians to apply.
I'd say to you, in the meeting I was in, there were people who are. It would not surprise me if they end up being in the administration, who, if they were in the administration, we would be having those conversations with them. But, as people have read, this administration is just taking its time in terms of appointing people. And so we don't have a whole lot of people we can talk to yet. So we can't go into depth, and we're reluctant to sort of assume things based on newspaper articles or comments from people outside of the health arena. So.
Questions? Here we go. I think we have some roving microphones, but if we can get them, and you could use this.
Thank you, Dr. Auerbach. I was one of those people who got to hear you twice now since in the last 6 months. Thank you for coming back to Ohio.
Thank you.
I'm really excited to hear the shift in your conversation around to the individual. I really appreciated that focus on your person.
Yeah.
I think so much of what we do in the healthcare provision is in the population health.
Yeah.
Very little on the patient experience side of things.
And when you say population health, you mean the practice, the patients in the practice, right?
I guess what I'm talking about is population health, looking at the statistical strategies around managing a population, not necessarily always managing the mean, not necessarily the outliers or the individuals. So it seems that personal economics might be the next thing to look at in some regards around the individual. And I think that's a significant contributor to the lack of good health outcomes for the individual. I remember hearing a stat about 5 years ago that only 50% of Americans make enough money to pay federal taxes. That equates into some pretty bad economic situations for our fellow Americans. Do you see any efforts underway to help benefit the individual's economic status as a way to help those individuals achieve better health outcomes?
Yeah, I think that's a great question. I would just say the data show definitively that poverty is correlated with poor health. And it's pretty direct. If you look at the highest level folks there and you look at the health indicators and then you go, down a quadrant, you see poorer health, and then if you go down another quadrant, you see even poorer health. And so we know there is a direct correlation between your income and your health. And there's been a lot of work that's looked at zip codes and place matters. And so you could have in Cincinnati, I'm sure it's true, that if you look by zip code, you probably see years of life difference in terms of just a neighborhood difference. You go a few miles and people's likelihood of having a longer life changes. So I would say if I was thinking half full, I think the positive part is that there's much greater recognition about this being key, about this notion of what we sometimes call the social determinants of health, with income being right at the top, as being directly related to health. I hear that across the country. Everybody uses that term. People talk about it in a routine way. They didn't 10 years ago. So I think it's progress to have it recognized as an issue. I think there's less progress in addressing it, to be frank. I think that there are ways of addressing it. People have different philosophies about address it. You can argue the way to address it is you create jobs, and if people have jobs, then maybe their income will go up. There are other ways of going about it that say there's certain things you can do that provide support and social services, whether those are food programs or job training programs or other, that can make a difference. As well as minimum wage. I mean, we looked at the data in terms of a number of those policies. So I'd say where I've seen innovation, it's been most obvious at the local level, not at the federal level or at the state level. I think that as I've looked at examples where people have focused specifically on what you're talking about with a health lens, it's been driven by communities where there may be a significant investment of money from a variety of sources, foundations or whatever, or where the public health department has had the support of a mayor to innovate on certain issues. Where those things have happened, I think we've seen evidence. So I'd say very uneven response is what I would say. But the fact that people are talking about it, I think gives us hope. Here's an expert on the topic.
Great.
So one of the things I would like to say is we have, Dr. Camille Jones in the health department has done adjusted life expectancy by neighborhood.
Yeah.
And so we have the data that's old now. They're in the process, and hopefully, without too many more cuts in funding, we will be able to bring out the most current data on that. But you're exactly right. In Cincinnati, we have the data to drive community-based interventions because we have 20-year life expectancy differences in neighborhoods that abut each other.
20
and
years.
So some radical needs and opportunities, I think, to do interventions here in the city of Cincinnati.
That's great. That's great. It's good to hear that data exists.
One more question, if there's, here we go back here. Or do we have, I'm sorry, go.
Is this on?
Yeah, she's first.
So I want to go back to the collaborative clinical care models, the team-based care models, and Dr. Schonk, you talked about this too, especially in Ohio. You say over half of primary care will be delivered by these models. And you discussed Dr. Auerbach a special interest in geriatric special programs. There's also a growing need for collaborative team care in opioid addiction.
Yes.
And I'm wondering what the interest is in expanding medication-assisted therapies. Really, everyone's talking about Narcan, but that's a Band-Aid, and collaborative therapy medication, is really limited by legislation also, and a lot of regulation on physicians. So what kind of collaboration is occurring there to expand those options for addicts?
Do you want to start in Ohio about some of the?
I can just weigh in a little bit. What we are actually convening a group of clinicians underneath the chief medical officers from the major systems in the Cincinnati area to look at where is the interface and what can be done on the clinical side with regard to that. One concept is to connect this screening and I think the studies show that 50% of the heroin addiction problem seems to originate in primary care offices from the prescription of opioids in an indiscriminate way. Can we, through our comprehensive primary care initiative, and they are actually required to link that to one of their milestones in transforming their practices to pay attention to behavioral health. Can that behavioral health be the addiction issues that are going on? And so that's one area, one avenue that we're exploring to connect those dots and say, okay, as a team, as a group of clinicians, can we impact the addiction problem that we're seeing?
Yeah, and if I were, I think that is very important. But I'd say my perspective is that the approach to behavioral health and opioid use in particular is that it needs to be a component of comprehensive primary care. And so what does that mean? I'd say first thing it means is you ask every patient, that patients, you create a mechanism for safe screening of patients about what's happening in their family, not just them, but their children. And then you have the training that people need in order to understand in a practice what can we do here, and that includes medical assistance treatment, buprenorphine and other approaches. That requires training and a commitment, and so people have to know, once you do the screening, what can we do here, what can't we do here. Third, I would say it requires knowing what's in the community, because if someone says to you, yes, I have a problem, I need services. As a clinician, you need to know where to refer them to. And ideally, it's more than a referral. It's a pick up the phone and find out, do you have a bed? Can you see this person? Can we make the appointment right now so that that person can we increase the likelihood they'll show up? I'll put them in a cab, I'll pay a voucher, I want that person right away to get the services that are needed. And we need insurance coverage that pays for the continuum of services, and we don't have that. I think our insurance tends to cover short-term detox, and we can cover outpatient and medical assistance, but we know people need residential treatment very often, and no insurance covers that. That's paid for with SAMHSA grants or by the public health or governmental sector. So I think thinking globally makes sense. And the final thing I would say related to the public health community, I used to be a local health officer, and we had a role in terms of prevention. So I would say in terms of that, we need to really think about not the very important role that the community can play in not inappropriate prescribing opioids. But another piece of that prevention is what's going on in the lives of the families where this is an issue. And we gave, I'll give you one example of things that can be done. We gave little grants to neighborhoods to convene interested organizations and individuals to become aware of their neighborhood-based issues related, again, to neighborhood by neighborhood. You see different data, and then focus on what could be done on prevention. So that involved getting often these little bit of money. You could get someone from the churches, the police, a neighborhood association, a recreation center, maybe half a dozen folks that were key. And very often we would find parents of children who had addictions. They had a lot of shame and uncertainty where to go. And we'd convene those meetings, and they would come up with neighborhood-based approaches. Sometimes it was, can we keep the high school gym open in the evenings so that there's a place for teenagers to go? Or can we have a little neighborhood support group for the parents who are feeling lost about what to do when their children have addictions? So I would say we need a comprehensive approach. You can't do all of that in a clinical practice. You can't do all of that with a single payer like insurance. You need your partnership in public health. But I think if we're really grappling with that issue, we have to think big, think kind of in those 3-bucket approaches, and make sure that everybody's doing something that's in a complementary way to try to improve the situation.
Well, join me in thanking John Auerbach
Thank you.
for
Thanks.
you did not disappoint. It was an excellent talk. We're going to break, but Susan, do you have some logistics here?
You all can understand why when I heard John Auerbach talk in Columbus in November, first break, I made a beeline to him and said, you have to come to Cincinnati. And we are so thankful. It's wonderful that he was able to take the time with all that he has going on. So we did change the location for our breakout sessions. Dr. Eckler and Dr. Graham are going to stay in this room. And then for the first breakout, the breakout 2 is going to be in that room, and then we're combining conference room 1 and 2 upstairs for breakout 3. So do that. Also, I was told that 2 cell phones were left upstairs. They're right here if anybody's missing a cell phone. We're selling them for what? And I do want to mention, also, I was in Washington with AACN a couple weeks ago, and we went to Congress, and we were fighting, those of us with AACN, to our congressmen, or not fighting, but encouraging them to support with Social Security 445 the home care for the elderly. And that's part of Title VIII. We want Title VIII to be funded. It's being one of the things that may be cut. And I also was a reviewer for HRSA on some rural grants that were all going to be dealing with behavioral health and Dakota, some of our most rural areas in the nation. So everything that John's been talking about can happen if we get the proper support. So in the meantime, we have fantastic breakout sessions ready for you. I wish we had time that you could go to all 3. So at this point, select one of them and go to one of these 3 areas. Thank you.